Our next speaker will be Chris Hammond. Chris Hammond was born in Salt Lake. He went to school at Brigham Young University, medical school at Western University in Pomona, California. He did his residency at Northwestern University School of Medicine. He is board certified by the American Board of Psychiatry and Neurology. He's the stroke director at Ogden Regional Medical Center. And he will speak to us about updates and acute stroke evaluation and management. Dr. Hammond.
Thanks for having me. Well, before I begin, I have to follow up on Dr. Ivester's comments. The Glasgow Coma Scale score, I presented my first time presenting on rounds to my chairman in neurological residency. It was my first presentation, nervous, Willie. He yelled at me, told me never to use the GCS again. Has its limitations, as I learned, and so I never use it. But it has its applications, obviously, research-wise and even clinically. Well, I'm going to up the ante. We're going to talk about stroke, and in terms of mortality, as we've been discussing on a few cases, but stroke is, well, let me ask you. I need to do some testing before we move on. Where does stroke lie in terms of mortality? Number 1, 2, 3. Okay, I see a 3. Number 3, good. And what is the number one cause of disability? Stroke. And so a few statistics we'll get into, just kind of understand the implications of stroke, what it has on society as well as medically. But what we need to understand is, first and foremost, the time-sensitive nature of stroke, because we're going to talk about acute intervention mostly in this discussion. So it is the third leading cause of death in the U.S. and second worldwide. About 25% of stroke victims expire within the first year of stroke. This is the leading cause of disability, and in addition, the costs are staggering. This $73 billion per year, I think, is actually a 2006 statistic. It continues to rise. As it states here, the average cost per patient for the first 90 days is approximately $15,000, and the mean lifetime cost is around $140,000. So approximately 800,000 people each year experience a stroke. 75% are first attacks and 25% are recurrent. And nearly every 45 seconds is a stroke occurring in the United States. So how do we go about recognizing? Well, this is neurology. Common being common, we see strokes every day in the emergency room, perhaps involving facial weakness, arm weakness, slurred speech. But a stroke can represent or induce anything that the brain is responsible for doing. So we're talking about not just speech or weakness, but also affecting visual processing, affecting sensation on different levels, and in addition to other cognitive problems. So a patient may present with confusion in addition to a Broca's speech problem, which represent a frontal lobe stroke. There's a whole host of neurological problems can be associated with ischemic stroke. Obviously, we don't have time to go into all of those types of stroke. Predominantly, we're going to talk about ischemic. This encompasses about 80% of all strokes. What we're dealing with mostly is thrombosis, intracranial thromboses, in addition, embolic or cardioembolic sources being the next common. Hemorrhagic stroke only making about 20% of types of strokes. What we're discussing in regards to hemorrhagic strokes is predominantly intralobar. Of course, subarachnoid hemorrhage and others are on this list, but we're not going to be giving it too much attention today. This is the vascular tree. This is what we look for when we see a stroke. Every vessel from the heart up is what we're looking at, especially in terms of cardioembolic sources or cerebral or extra or intracerebral thromboses. An example of what is this? External carotid occlusion, internal carotid stenoses with significant and near occlusion, however, with still flow. So one example of a cause of ischemic stroke. Pathological slides, we see the hemorrhagic intralobar stroke here, shown on the left, and then subarachnoid pictures on the other side. So I want to discuss a few minutes regarding to new definitions in terms of what's up to date on stroke. We can talk about the definition of a TIA now. Things have evolved in how we look at TIA. Transient ischemic attack, by kind of the traditional definition, means you have a short duration of neurological symptoms attributed to ischemia of the brain and without evidence of acute infarction. Timing, traditionally we say at least 24 hours, right? Less than 24 hours, if it clears up, we call this a TIA if there's no evidence of acute stroke. Whereas in ischemic stroke, we have evidence of that. Typically, symptoms last for more than 24 hours, and typically we have radiographic evidence of such. Now, what do we call TIA? Well, here's a case. So a 63-year-old male with transient left hemianopia for approximately 1 hour. His vascular risk upon history review, diabetes. Exam findings, and this is what your phone call from the EMS, they tell you he's essentially normal at this time except for elevated blood pressure. So he arrives to the emergency room, you have a CAT scan. Essentially normal, no findings. However, an MRI performed does show a right occipital infarct. So what do you call this? Obviously this is a stroke. But by TIA definition, traditionally, we'd call this a TIA because the symptoms only lasted 1 hour. So what we've gone through is essentially a reevaluation of what TIA means and how we should define this. And I do like the term acute neurovascular syndrome for communication purposes, if anything, because it does tell me that there is a neurological event, and we do suspect it is vascular in origin. And as a syndrome, composing of symptoms, obviously, leading to brain deficit or brain function dysfunction. So, in short, what we see from TIAs, most of them are at least 60% or less than 1 hour in terms of duration. 11% were 1 to 2 hours, 14% greater than 6 hours. And in fact, follow-up studies looking at MRI performed acutely or nearly acutely, TIAs lasting less than 1 hour may have an infarction up to 30% of cases, and around 60% of TIAs up to 6 to 24 hours. What is the incidence of stroke? Okay, so you've clinically diagnosed TIA. You don't have any imaging yet, but what is the incidence of stroke thereafter? Well, meaning symptoms clear up within 24 hours. This is the traditional definition of TIA. So within 30 days, you have a 4 to 8% risk of stroke. 90 days, around 10, actually to 12%. Then 1 year, it's around 12 to 13% risk of stroke. And so nowadays, what we use is radiographic evidence to actually help us in our assessment. We can use MRI. So clearly, if we see pictures of infarction, that is your diagnosis. You have a stroke. This is not a TIA. Of course, if you have a normal MRI and you have symptoms less than 24 hours, we may still call it TIA, although that definition, again, is under review. How can we stratify our risk assessment for these patients to determine, well, is this TIA something to be concerned about? And many of us are familiar with the ABCD2 score. And many emergency personnel use this regularly and determination for admission or discharge from the hospital. It is a helpful guide. It is not the end-all. We have to use it with some caution. In short, what we look for is age greater than 60 years old. That gives you a point. A blood pressure that's elevated, another point. Clinical features are important, and this is what we commonly see with neurologists when we do evaluate patients. The clinical features actually weigh in much more than anything else from my perspective. On the score, however, they give unilateral weakness 2 points, speech disturbance without weakness 1 point. D is duration of symptoms. Again, we're using timing nature of things. Less than 1 hour is 1 point. An hour or more is 2 points. And of course, if they have diabetes, which substantially increases the risk of infarction or recurrent events. And so the ABCD2 score can be practically applied and easily applied in the emergency room, and this can help determine your justification for admission or non-admission for these patients. Clinically, however, for example, often, and this is case by case, we have to apply some common sense with each patient and clinical expertise, in other words. And so not all comers are a high risk of stroke, even with a significant ABDC2 score, and vice versa. For example, sensory symptoms only and nothing else, they actually have a very low risk of developing further problems, especially if it's involving hand or foot numbness only. So 2-day risk for scores, compiling the ABCD2 score evaluation, 0 to 1, 0%. 2 to 3 on the score was 1 to 3% of stroke. 4 to 5 on the score was 4% of stroke, and then 6 to 7 is 8%. So the 7-day stroke risk for patients who scored 6 to 7 is 12%, and the 90-day risk of stroke is 18%. So, do we admit these patients? A lot of hospitals may have their protocols on what score to admit. In general, we say if it's more than 3, you should very much consider admitting these patients for further evaluation. Now, we do have to also talk about risk for strokes when we're assessing patients in the emergency room, because again, this is some further information that can help determine your risk stratification process to admit or not to admit these patients. Well, age is the number one risk. These are, again, non-modifiable factors that we have to be concerned about, and we'll talk about modifiable factors as well. But over the age of 55, your risk of stroke increases substantially. Male over female. Now, the exception is those 35 to 44 years old and those over 85 years of age. It's nearly equivalent. In fact, in the younger people, a slight increase on female with stroke rather than male. And race is quite significant as well. Family history, very significant. And in fact, I'll go over some genetics. In fact, I would like to go over a lot of genetic problems that we just won't have time to today. We're very familiar with coagulopathies that can be carried throughout in generations. Arterial dissections can be fibromuscular dysplasia. And in fact, we've identified several genes now that are in association with myocardial infarction for that genetic risk. So they are shared genes as well for both cardiac and cerebral infarction. I won't go into all this in detail. Obviously, there's a lot of familial problems that we have to be aware of when we are assessing these patients. So we do have to ask family history. It's very important. And then we can talk about the modifiable risk factors for stroke. And these are common things, being common, we're all very familiar with. I do want to highlight a few of these. The number one is high blood pressure. We all know that, in addition to smoking. Actually, when you look at the numbers, they're very similar in terms of risk of increase. Diabetes, heart disease, obstructive sleep apnea, carotid artery disease, and high cholesterol. Actually, cholesterol doesn't have a whole lot of very good data for cause of stroke, by the way, but has very good data for other types of ischemia. And so we apply that data very well, although now we have several studies, drug-supported studies, that do show that association quite well. And this figure here, the risk increase for tobacco use is actually underappreciated. It's much higher than that. That study they'll show you in a bit. The one study I do like was this composite study showing if you have hypertension, diabetes, smoking, and dyslipidemia, this substantially increases your risk if you have one or more of these comorbidities. In fact, if you have 3 of these risk factors, the incidence of stroke was found at 18%. Substantially higher if you just have an isolated risk factor. And so obviously, in your history review, you're going to be looking at all these medical problems. I won't go through the details of all the data that supports associations, cause and effect from all these risk factors, but smoking is high on the list. And secondhand smoke, interestingly, I was very interested in this study because I have many patients that say they never smoke, but it turns out they are exposed quite a bit to secondhand smoke. This substantially increases the risk. It is a very interesting study, and something that I think a lot of us do need to educate our patients regarding their risk for stroke, even though they don't directly smoke themselves. What about alcohol? Well, we see positive reports of alcohol reducing ischemia. This is a negative study showing binge drinking, which means, by definition, 6 or more drinks for men at a time, which typically is a weekend. And for women, it was 4 or more drinks. And this substantially also increased the risk of stroke. sleep apnea is also kind of more of a newer finding for its risk factor for stroke, with Yale performing this study that was published in the New England Journal. So, stroke. Well, the old adage, or rather new adage, time is brain, and that strictly applies to the advanced therapeutic with thrombolysis, that we can intervene sooner, and the sooner the better, because if we wait, we have less effect with TPA. And that's going to be the focus of most of the rest of this discussion. So where does it start? It starts with, actually before EMS. That's the first on my list, but I was thinking, no, it starts much earlier than that. It starts with the patient and the patient's family quite often. And that's why we see many organizations and efforts in our community going out and educating. Because it does start with the patient being able to recognize their own symptoms, and quite often they can, if they're well informed. And then, next, family members. And so it does start with them, because the biggest and most important thing is recognize, well, this is a stroke, or could be a stroke, so let's get emergency personnel here. And then the next thing to recognize is, well, what time did this start? So timing says a lot, and it impacts our clinical decision remarkably. So we have to know the exact time. Otherwise, we're not going to be able to help them as much as we like. And so what do we do? The first thing often is a CAT scan. We get a CT of the head to ensure that, number one, there's no hemorrhage. And number two, we can also assess the evolution of stroke and determine their TPA candidacy. We also have to get lab studies. These are stat studies looking at their coags and so forth, hemodynamics, and of course the neuro exam. The neuro exam is essentially made up of what we call the NIH stroke scale. This is the national, well-recognized, research-based scale to help us assess patients, where we can essentially categorize them and determine if they are candidates for acute thrombolysis. So this is established, reliable, and reproducible, and essentially required to be used by stroke centers and anybody treating stroke for that matter. And this is recognized by the AHA-ASA. Now, in practice, and should be administered before imaging, before a CAT scan. However, CAT scans shouldn't necessarily be postponed. Now, the NIH stroke scale is better used for ischemic strokes. It hasn't been well tested or validated for hemorrhagic strokes. And again, and then the one caveat that I always have to tell physicians is the stroke scale is not all-inclusive. It should not be used as a complete neurological examination. Well, of course, I'm not going to go into the details of what the stroke scale is, but this gives you an example of how complex it can be, although with practice it can be done fairly rapid and within a minute or less with good practice. So you do have scores that go up to 42, but again, with practice, it can be done fairly quickly, well memorized, and you can do this with every patient that comes in for stroke, and I would say in a minute or less. And so very practical, and it gives us a very good guide. So what about imaging? Well, we often get a non-contrast CT to start with. Again, the idea is to eliminate possible hemorrhage. Now that we're starting to see multimodal CT scans, which can be helpful to assess what we call the penumbra, or the area of tissue of the brain that still may be preserved that we can potentially salvage with thrombolytics or with mechanical devices. And this is one example of a CT perfusion here on top, demonstrating areas of infarction or near infarction, but rather demonstrating poor perfusion with attention to the right hemisphere. And now that's a CT perfusion. We also have MR perfusion, which can assess this in a similar way, which we see on the bottom. On this graph, we actually show quite a bit of infarction within the left hemisphere. And in addition, we see significant perfusion deficits throughout, suggesting that a lot of this brain probably won't be well salvaged. Now, multimodal CT and MR may provide additional information. My concern is, will it delay significantly our time for getting TPA? Well-established academic areas that utilize CT and MR, it may take them 1 minute. Not significant. Centers where we're still getting experience, it may distract us. it may require a little bit more time, and that is one of my concerns at present. So the AHA or ASA recommendations that vascular imaging may help in deciding between intravenous and intra-arterial thrombolytic therapies, but should not delay an IV TPA. That is an important point to consider. Now, vascular imaging can also be performed or considered if intra-arterial therapy is being considered. And that's where I kind of raise my hand on. Let's just hold back, and if we're considering intra-arterial measures, then how about we get a perfusion study? How about we look at the angiogram? Certainly if they're not a candidate for IV TPA, which we'll go into in a minute, that should be considered. Concerns for CT-related contrast, negligible. One follow-up study, they looked at several patients, over 1,000, 4.8% led to a creatinine rise greater than 0.5, 0.37% contributed to renal failure, and only 0.19% underwent temporary hemodialysis. And this is all comers. This isn't in people that were felt to be safe for contrast. This is all comers that weren't screened. So when a person does come in with stroke, obviously we went through family history, their own history, and so forth. Your differential diagnosis is extensive. Things to consider, however, are seizure and, of course, hemorrhage, which we've essentially or effectively ruled out with the CT scan. Of course, other things to consider, a complex migraine, and so forth. I don't have a slide, but speaking of which, there was a Texas study showing, well, what happens if we give TPA to these patients that actually didn't have strokes? In fact, several hundred, I think it was 200 to 300 patients that they did a follow-up review on that received TPA for non-ischemia. There were zero deaths, and essentially no significant complications. So the concern there was somewhat alleviated by the study from Texas showing that if there's a question, of course, we want to be confident with our diagnosis, but some of these can be very complicated, especially when you're dealing with a hemiplegia migraine. You just don't know. And these can be middle-aged people with risk factors, and so they're hemiplegic, and it is neurological, but in fact can be non-ischemic. Well, the reassuring aspect of this study, the risk is substantially low if we decide to go with thrombolysis. So, what else about CT? We use CT also in determination to guide our therapy. If the CT shows too much, we may not want to give TPA, the general rule. The things we can look for early ischemia, insular ribbon loss, gray-white differential loss, loss of sulci, acute hypodensity, mass effect, and the dense MCA sign. These are all findings that we can correlate and use as a guide. Now, more often, though, what we see in the emergency room, the CAT scan's normal. So, how do we go about deciding to treat based on CT alone? Well, subtle signs, as I mentioned here, looking for all these early ischemic changes. If it's less than 1/3 of the MCA territory is a common example, but less than 1/3 of the hemisphere in general, we should treat. If it's more than subtle, it's questionable. We have to be cautious. But certainly more than 1/3 of the hemisphere, we have to be cautious, although not completely contraindicated. But we do have to be cautious. Now, if it's more obvious, and then what we're talking about obvious is hypodensities. So your CT is black in certain areas or near black. And then we may want to exercise caution again. But clearly, if there's hypodensity that composes more than 1/3 of the hemisphere, then we don't treat. Why is that? Well, significant hemorrhage was identified with administration of TPA for those cases. And so a lot of us are using volumetrics now, and I do encourage radiologists to use that when we have a CT or an MRI for that matter, because volumetrics can actually help us. If there seems to be, I think it's somewhat arbitrary, but there seems to be a cutoff of 100 cc's. If we see that kind of a change, then we may need to consider non-thrombolytic therapies. So, okay, I'm going to have to move pretty quickly here, and some ideas on TPA. We can use up to 4.5 hours for selected cases. In general, up to 3 hours for most cases. Of course, intra-arterial can go up to 8 hours in some centers, 6 hours in others. Some centers are going up to 12 hours. If it's a posterior circulation event, such as a basilar stroke or thrombosis, they may go up to 24 hours. More often, we do reserve mechanical thrombolytic therapies or thrombolysis instead of. So TPA is a standard of care. There is no question of that nowadays, and I hope there still isn't. I'm happy to entertain that question. It is standard of care. There is plenty of data from the ECAS studies, from European studies, as well as American studies, showing a great benefit with thrombolytics, specifically with TPA. And now, I'm just not going to be able to go over each of these studies, but the data is there. And in short, what the data shows is a reduction of disability in 3 months, and some studies going up to a year. In 3 months, however, disability reduction is 12 to 13% in short. There's some variation there from study to study, but that is about the average. And in fact, the early studies did not show an increase in mortality with TPA administration. In fact, a newer study released actually demonstrated reduction in mortality with TPA therapy, although there's been some mixed results with that. Time is brain, the earlier the better, and this is the message I do want to get across. This UCLA study, among others, have shown a significant reduction in both complications of TPA, in addition to reduction in terms of disability by early use of TPA. So outcomes favor substantially. If we can, the sooner the better. And I know most centers are saying 1 hour, and now we're pushing up to 4.5 hours. I do want to get to that slide. I'm not going to go over exclusions of thrombolytics, obviously. I just don't have the time for that large slide. Now we're talking about 4.5 hours is that new window of opportunity. Oh, there's some exclusion criteria that we have to be aware of. An night stroke scare less than 26, a blood glucose of 50, a systolic blood pressure less than 185, age less than 80. These are all not exclusions, rather these are inclusions, and not on anticoagulants and no history of stroke and diabetes. So these are inclusions. If they go beyond these things, then that is an exclusion. And so we can go up to 4.5 hours up to that point. However, TPA is not FDA approved for that. However, the ASA does recommend it in terms of their guidelines, so this is a possible consideration for these patients if they meet this criteria. They may be candidates for TPA. The goal in general is 60 minutes from time of arrival to the door of the emergency room to actual administration of TPA. This is a guideline set by the ASA nationwide, particularly for those centers that are interested in stroke management. And the Joint Commission has set guidelines and with encouragement on both the federal and state level to ensure that patients are getting well treated with their strokes. I think 60 minutes is too high, and I think centers can cut this down to much less than that, and that would be the ultimate goal, because the message here today is time is brain. I should probably stop here and ask if you do have any questions. Yes?
Are you recommending someone who presents with TIA type symptoms and a negative CT be admitted and get MR? Because the first slide showed the negative CT with the positive stroke and MR.
Yes. The question is, if a person does have a true stroke, and we have to define a stroke, which means radiographic evidence, especially if they're within the first 24 hours, and if there's radiographic evidence of stroke, should they get TPA? If they have an MRI before TPA, the answer is, and we see stroke, and they're still within the criteria, they're still a candidate, the answer is yes. Because what we often see, and can demonstrate on perfusion studies, these patients will often have the so-called penumbra, which means ischemic tissue or a tissue that's prone to become infarcted, but not quite there yet. So it meaning you have poor circulation, poor blood supply to that area, and we can actually preserve it. So one option is you can include with an MR, an MR perfusion scan, to help determine that person's if they would respond well to that. Because again, what we're looking for is penumbra. Is there tissue there that we can save? Because quite often with the standard MRI, you're just looking at tissue that is dead. There's nothing you can do about that. TPA is not going to help that. But quite often, though, you've got a surrounding area of tissue that we can salvage. So the answer is yes. If they're candidates otherwise, they should be administered TPA if there's no other hazard findings on CT. Yes? Okay, the question is if they've had a hemorrhagic stroke, what is the general treatment for that anyway? In general, we do avoid anticoagulants and antiplatelet therapies for those patients. Is that all patients? Not necessarily. For example, we do have ischemic strokes that undergo transformation into hemorrhagic events, and we may determine anticoagulation is a viable option for them at a later point, especially if the stroke is large. We may hold off for a while, and then if they have atrial fibrillation, for example, we may initiate anticoagulation at an appropriate time point. Acutely, no, though. We're not going to initiate anticoagulation, especially if they're moderate to large strokes. We may hold off on that, even for ischemic transformation-related strokes. Yeah, and that's a very good point. And we have to determine what caused a hemorrhagic stroke, for example, and quite often intralobar strokes that are hemorrhage may actually be due to an ischemic event. And so we still may consider antiplatelet therapy. So with family history or other comorbidities suggesting a significant risk for stroke, then we still may consider antiplatelet therapy for those cases, yes. Yes? No, and that has been studied. Small studies, though, and it hasn't showed any significant outcome. However, I need to follow up with Dr. Ivester's comments regarding therapeutic hypothermia. The studies are undergoing that. They've had a couple of small studies that didn't work out. There was a good trend for benefit, though. But in terms of preventive therapy for stroke or advancing stroke for those acute events, we feel that hypothermia therapy may be of use in the near future. So that may be an upcoming therapeutic option for patients. Yes? Well, that's a very good question, and that's why I like to apply the ABDC2 score, D2 score, even in the clinics. I think we can justify that. Again, kind of in a nutshell, sensory symptoms only, your risk of stroke is significantly low. If they have motor components, motor deficits, then I think your threshold for bringing them to the ER should be lowered. I think there's cause of concern if they have any motor deficit whatsoever. Again, you can apply the ABCD2 score effectively well. With anything 4 or more, certainly. 3, you can use some caution there. Yeah. So I would use caution in the outpatient setting because, again, you saw the numbers. If it's within an hour, they have a 60% risk of stroke. Or within 24 hours, within the 60 minutes, it's about 30% risk of infarction, actually. So, okay, all right, thank you very much.
Thank you, Dr. Hammond.